Hi, I'm Sean Fix with Emergency Medical Consultants. We're a national training center for a number of organizations providing continuing education for healthcare providers, fire, EMS, and industry. This video series that you're about to look at is designed to help you prepare for a certification course. Remember that it's not designed to make you leave your required manual or not do your required pre-course exams prior to entering the course. It's also a great review just for clinical practice and relevance. So this section is going to overview the concept of ACLS resuscitation. ACLS began in the 1970s and obviously has continued through this year and this certification cycle. In the 1970s through about 2000, resuscitation success rates were approximately 5%. That meant that 95% of the patients we're trying to resuscitate still did not survive. As we move forward into the year 2000, 2005, 2010, and the 2015 guidelines, what we've seen happen is a decrease in the amount of advanced skills that we're doing. That is, we're giving less medications, or at least less emphasis on medications, and more emphasis on good basic CPR. So correct CPR with early defibrillation really seems to make a difference. While the studies vary as to the resuscitation rates, we see places reporting 30 to 55 or 60% return of spontaneous circulation, along with somewhere in the 10 to 35 or 40% discharge patients from the hospital after cardiac arrest. So we're going to look at how we manage these patients throughout the cardiac arrest process from start to finish. This section is going to remind us that the most important part of ACLS is to continue good BLS or continue coronary perfusion. Continual CPR in 2-minute increments is the key to this. At the end of the day, though, what we really want to do is we want to have cerebral resuscitation. That is, we want our patient to leave the hospital intact neurologically and able to walk out and function versus being sent to a nursing home decorticate and trached as our, quote, resuscitation. So the way to do that is to increase cerebral perfusion. The way we increase cerebral perfusion is to do early, good, aggressive CPR. Then what we need to do is get the patient's pulse back, meaning that a patient's own pulse, the heart working on its own, is much better than CPR perfusion, even good CPR perfusion. So we want to maintain a blood pressure and then keep that blood pressure up in the area of systolic of 90. So remember that we say basic life support needs to be done before advanced life support. Once we've gone through the process of resuscitation, we then can start looking for causes. And in your algorithm or in your prep packet or in your textbook, there's a list of things that start with H and start with T, which we'll review in a few minutes, that are reminders of why this patient may be in cardiac arrest and things that we might have to do which may be outside the standard thinking of ACLS in order to try and resuscitate them. So since the latest guidelines say that CPR is so important, remember that we have to do good effective compressions, and that is a compression rate of 100 to 120 compressions per minute, pushing hard in the adult. That is over 2 inches. It's 2 to 2.4 inches deep. I'm not really sure what 0.4 inches means, but that's what we need to recall. And we need to push non-stop. So since that has occurred, we've seen a resurgence over the last maybe 10 years of these CPR machines. So again, those of you that were doing EMS 40 years ago saw CPR machines called the thumper. Now we see some refined and better devices that are out there. American Heart Association and the ECC Council and the Red Cross and all of the resuscitation agencies all basically say that whether you're doing manual compressions or whether you're using one of these CPR devices, the success rate seems to be about the same as far as discharge from the hospital. Another concept that becomes important is post-resuscitative care and target temperature management, or what some people call induced hypothermia following cardiac arrest. Patients who are cooled after cardiac arrest to a temperature of 32 to 36 degrees Celsius for 24 to 72 hours seem to do better neurologically. This is only indicated in patients who don't have an appropriate response to pain or voice following cardiac arrest resuscitation. So when we talk about pharmacology, a couple of things that I need you to remember. Number one, continual compressions are more important than any drug. Number two, the person who's giving the medications needs to be familiar with giving those medications. That's the reason in the hospital setting we call a code team to respond to a cardiac arrest outside of the critical care areas, so that we have a physician or an intensivist physician or an ER physician or a hospitalist who's familiar with ACLS as a team leader, so that we have the respiratory therapist doing the airway management skills, so that we have the ICU or the ER or the critical care nurse pushing the medications. Those of you in the pre-hospital setting, you end up being a jack of all trade, and you have the best airway person do the airway, you have the person who knows the medications giving the medications. Remember that sometimes the science will change, and we may see that as we discussed it here today. Science may change before the textbook changes. That is, there may be recommendations and procedures and medications that have not been added into the most current version of the textbook. So you may see physicians who are choosing to modify ACLS a little bit from what we know or think is the standard. The doses that we're looking at here and the procedures we're looking at here are going to be the current standard for all of us that are looking at the guidelines from national curriculums. And the bottom medications, the Maalox, Imodium, and Pepto, that's for you when you take your class and have to take a test to reduce your anxiety. When we look at pharmacology and accessing the circulation with medications, here's the recommendation. The recommendation is that if you're starting an IV during a cardiac arrest, that you do a standard peripheral IV. Ideally a large bore IV, which becomes relevant to where you work. The emergency room or EMS might say that would be a 16 or a 14 gauge if possible. The non-critical care areas of the hospital might say that's an 18 or a 20 gauge. At the end of the day, what you're hoping for is vascular access. If you're not able to get an IV, or if your IV comes out in the middle of the rest or is infiltrated and you can't quickly start an IV, the recommendation is that we go to the intraosseous route after that. And that is versus trying to put in a central line or something more advanced. Intraosseous, quick and simple. Here's what we know about any medication that's given during cardiac arrest when the patient has poor blood flow. That is, the blood flow that you have is just CPR. Number one, push the medication early on in your 2-minute CPR sequence so that you have 2 minutes to get that medication around. Number two, flush the medication in afterwards to move it from the IV site closer to the central circulation. So really all you're doing is pushing the med a little bit further in. Whether you put an IV push behind that, whether you open up the IV bag and squeeze it for 20 seconds or so in your practice, one way or the other, increase that flow of the medication, and then circulate it for 2 minutes of CPR before we stop and reevaluate the patient. So when we look at intraosseous, there are several devices on the market now. Intraosseous was around actually in World War II with the medics, and then it stopped after World War II because there were no more medics. Probably in the early 1980s, and maybe even earlier, we used it in pediatrics when we had a pediatric critical cardiac arrest or unconscious patient. We would use that as vascular access, usually in the tibia or medial malleolus with one of the manual devices. There's a spring-loaded device, there's a drill device on the market, there's several devices that have been used and will continue to be used in the adult setting, child setting, and infant setting, all giving excellent vascular access. So there's one device that's put in the sternum. There's one device that can either go in the humeral head or the tibia, and there's one device that is mainly developed to go into the tibia. The device that you have access to obviously will dictate which way you put the vascular access into the patient if you don't have a peripheral IV site. So looking at some IOs, This first one is some flight paramedics who are practicing on each other the first day they got there.
That's it? There you go, stop. Yeah. Oh, there you go. Okay, now hold on. Twist it counterclockwise. Because remember, you don't want to touch anything directly to it.
Okay, let me get another picture here.
Yeah, that's not true at all.
So this is at a conference, a physician practicing this on a attendee.
That's one.
She says it's a 1. Do I have an easy connect?
But you had the same expression.
It has a lot to do with the skill of the doctor doing the procedure. See?
Do you have a wristband and look sheet?
It's getting pale and pale. Aspirate. Sometimes you can aspirate, sometimes you can't. There is the aspiration.
Do you feel okay, Lydia?
Okay, and then to remove, this should not hurt at all. We're all done. We have just a little bandage.
This is just showing how fast the vascular access is obtained when medication is pushed through the humeral head and into the heart, how quickly it goes. This last device is the one that the military use, and this is military practicing on each other.
Okay. You got good anesthesia?
Yep, I got 5 cc's on board.
Good angle, right?
Push down, both hands, push down. There you go. That's what's supposed to happen. Pull it out, come on out.
Did it hurt or just pressure?
No, just pressure.
Okay,
A lot of pressure. So
go ahead
you already got blood
put that on there before you leave.
Perfectly.
There you go. Bueno. So, all right, we see what happens, right?
So while some of these
That goes there,
devices
good job.
are approved for any vascular access requirement, frequently we mainly see them used in the emergency and pre-hospital world in the critical patient where vascular access is not obtained. Certainly they could be used any place in any facility where vascular access required, provided the people are trained to use the device. So as we start looking at putting together the team who may show up to find the patient, and I'm not talking about the code team, I'm talking about whoever comes in and finds the patient, remember that the CPR sequence says CAB, and we actually added D to that, which means get the defibrillator, because that's probably the most important device that you'll bring to the patient. Once the team is together and we're going to do the advanced assessment or the primary assessment for cardiac arrest, we'll use the acronym ABCD. So the first thing that should happen when we find a patient in cardiac arrest is we should evaluate their effective breathing and their level of consciousness. That is, do they respond and are they breathing effectively? If the answer is no to either one of those, we should check their pulse. And we know that CAB says circulation, airway, breathing. Immediately upon recognizing that the patient is not responsive, we should activate whatever code recognition we use in our system, whether it's call for extra assistance in EMS, whether it's call a code in the hospital, whether it's call 911 from your medical facility. What you're doing is trying to get a team there as well as a defibrillator. So when we look at C, circulation. If there's no pulse, assess and compress is what we say. Start compressions, regular CPR, 30 compressions, 2 breaths, 100 to 120 per minute, 2 to 2.4 inches deep in 2-minute cycles before you reevaluate the patient. A, after the compression. C, A, open the airway and give 2 breaths. Breathe with a ventilation device enough to make the chest rise 2 times slowly. And then we add D, which is get a defibrillator in the room. Whatever type of defibrillator you use in your facility. Now, the energy setting will be dictated by what defibrillator you use. So the science says the joules would be set from somewhere between 120 and 360 joules. And what that means is this. If your hospital uses the Zoll defibrillator, the recommendation from that company is they start at 120 joules, increase every 2 minutes, and the machine doesn't go any higher than 200 joules. If your facility uses the Philips defibrillator, the recommendation is to start at 150 joules and increase every 2 minutes if needed, and that machine only goes to 200 joules. If your hospital uses the Physio Control LifePak defibrillator, The recommendation from that company is to start at 200 joules and then increase after that, and that machine will go to 360 joules. AEDs, automatic defibrillators, are discussed, but generally are not part of the ACLS providers' equipment that they use on a regular basis. So what that means is, if you're an EMS provider, you're probably using a regular defibrillator. If you are a hospital provider, you probably are using a regular defibrillator, that is a manual defibrillator. However, there may be some settings where you are using an AED, a supervisory car, a hospital outpatient area, a hospital education area, a certain building, certain non-critical care areas of the hospital. So even though in ACLS we don't generally use AEDs, certainly there are cases where you might use an AED. And the AED is basically going to determine the rhythm for you, shock at its predetermined energy level, and all you have to remember is turn the machine on, follow the directions, and do what it tells you. The primary assessment after the CABD is when the code team arrives and we're doing some more advanced procedures as appropriate. So the A is advanced airway management, and advanced airway management might mean bag valve mask oral intubation and then put in a laryngeal mask airway or an IGL airway or some other paralaryngeal airway. It may mean that we delay that until a little bit later on in the cardiac arrest at the team leader's discretion. Whatever device is used, the B in ABCD is breathing assured. Make sure that the device is put in properly by listening to lung sounds, listening to abdominal sounds, or at least the absence of the abdominal sounds, attaching oxygen to the device, and then measuring exhaled CO2. The circulatory intervention basically is make sure we're compressing adequately, that we have vascular access, we're interpreting the EKG rhythm, and start the cardiac pharmacology when appropriate. The D is look for disability, which is level of consciousness in that patient who may not be in cardiac arrest. If we're doing a neurological exam because they're not in cardiac arrest, what are their pupils? What is their glucose level? E is expose and examine as appropriate. So if we have a patient who's cardiac arrested outside an EMS or shows up in the emergency room, we might need to remove clothing to look for injuries, to look for medication patches or something like that. So exposure and then exposure control. If the patient's cold, warm them up. If the patient's hot, cool them down. The secondary exam that ACLS discusses looks at a couple of things. It looks at a focus history based on the patient's problem. So we want to use the acronym SAMPLE. That's the quick, down and dirty information that physicians may need as they start to manage a case. So they want to look at what are the patient's signs and symptoms. What are the patient's allergies, especially to medications? What medications are they currently taking, or what medications have they been given? What is their past medical history as appropriate to this event? When was their last meal eaten? And what are the events that caused this current medical situation? When we look for the underlying causes, I mentioned earlier that we're going to look at things that start with H and things that start with T that may help us in determining what the cause of the cardiac arrest is, or what we may have to do outside of the standard ACLS management. So again, if you look at your trifold, your textbook, your prep packets, the H's are things like hypoxia, hypovolemia. Obviously, those are two of the most common causes of reversible cardiac arrest. Hydrogen ion, which is metabolic acidosis, hyperkalemia, even hypokalemia, or hypothermia, significant hypothermia. The T's could be toxins, which is tablets or overdoses, which we know we see a lot of currently. Thromboembolus in the pulmonary artery, thromboembolus in the coronary vessel, cardiac tamponade, or tension pneumothorax. So each of those things are ruled out as we move on. The next section that was added into ACLS probably in 2010 is the section on reducing errors. And what that talks about is, number one, having the right team player in the right spot, which I mentioned earlier, putting the respiratory therapist at the airway, putting the person who knows the medications best at the meds, putting several people to move in and out of the compressors spot so that they don't get fatigued. Remember that each member has to function within their scope of training. So that is an example of a non-critical care nurse in a hospital whose floor does not use Diprivan to sedate patients. That person should not be assigned to administer Diprivan in the middle of a resuscitated patient. So the provider needs to be responsible if the team leader tells them, I need you to give me Diprivan, and it's not something you do. The provider needs to be responsible for letting the team leader know, hey, we don't use Diprivan on our floor. Can I get another task and have one of the ICU folks give the Diprivan? So that's just using one example. Remember that reducing medical errors, when we have a lot of people in the room and people talking back and forth, we should have one scribe who's documenting. We should have one person who, when they're given the direction of what needs to be done, uses what we call closed loop communication. And that is, if the physician says, give 1 milligram of epinephrine, the team member should say, I understand, I'm giving 1 milligram of epinephrine, and somebody should document, hey, at 2 o'clock we gave 1 milligram of epinephrine, and then every 2 minutes should let the team leader know that we're coming up on 2 minutes so they're prepared for the next procedure. Any team member who recognizes an error taking place, if the respiratory person is ventilating at 1 breath every 2 seconds instead of 1 breath every 6 seconds, somebody in the room needs to be responsible for correcting that error and catching it now rather than talking about it at the end of the cardiac arrest. So our goal in ACLS is continual high quality BLS, add a defibrillator, and then move the ACLS procedures in if appropriate. One of the new concepts in creating an organized, coordinated team is what they call pit crew CPR. The introduction of the pit crew approach to CPR is designed to enhance organization, teamwork, and effectiveness during a cardiac arrest. That is, each person is assigned a specific task to perform during the resuscitation. Many times, this assignment is done prior to a cardiac arrest even occurring. That might be at the beginning of the shift or sometime during the day to say, hey, if we have a cardiac arrest, here's what you'll be doing. This concept has worked out very well in increasing the effectiveness of CPR and early defibrillation, and is shown to be very successful at increasing return of spontaneous circulation. One of the other devices that we're using now in resuscitation to help us evaluate several things is waveform capnography, or end-tidal CO2. That is, we're taking the patient's exhaled air and measuring how much CO2 is in that air. What this does is it really measures the ventilation or the perfusion of blood through the lungs. So what we know is that in an intubated patient, if a tracheal tube is put into the trachea, we will get a waveform and a value number as the patient exhales. So one of the things that we use this in ACLS for is to determine, along with our clinical evaluation, is whether or not the tube is in the trachea and if it's effective. The other thing that we use it for is measuring the effectiveness of our compressions. What we'll talk about in a minute is the fact that a normal patient with a normal perfusing heart, that is a pulse, will have an end-tidal CO2 reading, or a waveform capnography reading, of 35 to 45 millimeters of mercury. Now, CPR does not work as well as the patient's own heartbeat, so what we generally see in cardiac arrest when we're measuring end-tidal CO2 is a waveform reading of approximately mid to low teens, sometimes high teens. What the guidelines tell us is if the patient doesn't have an end-tidal CO2 reading of at least 10 while you're doing compressions, you need to do better compressions. If it remains below 10 after approximately 20 minutes of resuscitation, the survival rate is essentially 0 for that patient, and that could be one of the things we use to determine termination for that particular patient. So a couple things to remember. End-tidal CO2 is acid. The normal is 35 to 45 in the breathing patient. It's going to be in the teens for a patient who is receiving CPR. If the patient is breathing or post-resuscitatively, the CO2 may be a little bit high because he's been acidotic while he was dead, for lack of a better term. If the CO2 is low, this tells us there's a poor cardiac output. It could be that the patient is receiving CPR. It could be the patient is decompensating from shock. It also can mean, in a healthy patient, that the patient is hyperventilating or being hyperventilated. But for ACLS, we're really worried about two things. Number one, is it above 10 when we're doing compressions? And number two, after intubation, am I getting a CO2 waveform and reading? Let's talk about terminating the resuscitation, because a lot of people ask that. This is generally the physician or the team leader or the physician extender's decision on this. And what it takes into account is a number of things. Number one, are we doing the appropriate resuscitation, and have we been doing appropriate resuscitation for 20 minutes? And do we have no salvageable EKG? And or is the CO2 remaining below 10 with good CPR? Have we done everything appropriately? Have we discussed the patient's wishes and the family wishes? And does the nursing team or resuscitation team have any other input? And if nothing has been successful, termination at that point. And for EMS, some of the recommendation in some areas is that they terminate before they transport to the hospital. Contact the receiving physician, discuss the procedures that they've done, and if there's a policy for terminating it, because there's not any new or special drugs at the hospital, provided there's no extenuating circumstances that you might be able to reverse. If your patient is live and complaining of a cardiac event, that is chest discomfort, shortness of breath, syncope, unexplained dyspnea, some things that need to be done to evaluate them. If the patient is serious and we're in the hospital, we would contact a rapid response team, a patient with decreased consciousness, serious chest pain, bad vital signs, level of consciousness diminish, something like that. What we want is, I want a problem-focused history. I want to know what happened right now. I don't want to know about 7 years ago you had your knee replaced. I want to know what happened right now, what the symptoms are. Bedside clinicians should put the patient on whatever monitors you can get bedside. So that could be blood pressure, pulse ox, EKG, etc. If they need oxygen, give them oxygen, which we'll talk about in the next section. Make sure that you have a patent IV, and then things that are going to most likely be ordered, if you're not allowed to do those automatically yourself, would be a 12-lead ECG to stratify them for cardiac events, would be labs for cardiac enzymes, and possibly a chest x-ray. Those are the things that we do for all of our live patients. This has been an overview of Introduction to ACLS and Managing a Case.